Welcome to Open BxRx Tuesday on BronxNet. I'm your host, Kibin Alleyne, and I'd like to invite you to get social with us at BronxNet TV on Instagram and Twitter, and BronxNet Community Television on Facebook. It's the third most common cancer in men and women, and the third leading cause of cancer related deaths in the United States. In the month of March, health professionals dedicate time to spread awareness on colorectal cancer. Joining me for a discussion on this is Dr. Darlene LeFrancois, primary care physician at Montefiore Health System. Doctor, thank you so much for joining me.
Thank you for having me, Kibin.
According to NYC.gov, every year about 1,100 adults die from colorectal cancer, and more than 3,500 New Yorkers are newly diagnosed. Can you tell me what colorectal cancer is and how it affects our bodies when diagnosed?
Sure, it's a very important cancer to be aware of, and as you noted, it's a very highly leading cause of cancer-related death in the United States. So we need to be aware of what it is. It's a cancer that forms in our large intestine, and it happens because the cells in our intestine can lose pieces of chromosomes or even entire chromosomes. These things are called mutations. And these mutations can actually change these cells into cancer cells. First, there's this development of polyps that can happen. These are abnormal growths in the inside or lining of our intestines. And then these polyps can actually evolve or change into cancer. So it's a very important topic that we talk about today.
Now, to avoid confusion, can you explain what the difference between colorectal cancer and colon and rectal cancers? Like, is there a difference between them?
Yeah, it's a great question. So colorectal cancer is the term we use to describe like cancers of both our colon and our rectum. But the colon and the rectum are sort of the large intestine as a whole. There is some important differences that the rectum it's just the last few inches, if you will, of the large intestine. It connects to the anus. And it has these kind of really interesting nerve wirings that tell our brain when we have to go and use the bathroom or defecate to relieve ourselves. So there is some differences in these two organs, if you will, but it's all large intestine, and together we consider it colorectal cancer.
Okay, thank you so much for that. Now, can you tell us how does this actually start? You told us a little bit about polyps, but how does this actually form or start in your body?
Yeah. So, I mean, polyps are these abnormal growths. They're starting in the inside of the large intestine, inside the colon or rectum, and then they can, as through these mutations, which I mentioned earlier, can evolve into colorectal cancer. The pathology doctor who gets these polyps after you've had a test to remove them, it's very important this pathology doctor look under this microscope to determine what kind of polyps they are and how severe they are, how much risk they pose for the development of cancer. And the really amazing news about this, I'm so glad you asked this question, is that if you can remove these polyps before they turn into cancer, you can actually prevent the development of cancer. So it's just really exciting news that I want to get the word out about.
Now, can you tell me some common risk factors associated with colorectal cancer?
Of course, yeah. Unfortunately, there's many risks that we can't change. We call these non-modifiable risks. Things like older age, over the age of 50 is a risk. Black race is a risk. And male race is a risk. Men have about 25% increased risk compared to women for developing colorectal cancer. And so these are all things we cannot change. Personal and family histories of either colorectal cancer or these kind of large or high risk adenomatous polyps, these polyps that are adenomas that I described earlier, those are all risks that we cannot change. But the good news is there are some risk factors that can be changed that we call modifiable. Things like being overweight or obese, smoking, alcohol use, a diet that's high in red or processed meats, red meats like lamb and pork, beef, and liver. So this is the good news that many of these factors are things that we can, and in the lack of exercise, I should also, of course, mention. So these are all risk factors we can change, and those are the ones I like to focus on with my patients. But of course, it's important for everyone to be screened so that we can lower the risk of developing cancer.
So you touched on it a little bit, but I kind of want to dig into it a little bit more. According to the American Cancer Society, African Americans have the highest mortality rate of this cancer in the US, while some Jewish communities experience the highest colorectal cancer risk in the world. What could be contributing to this outcome? And we see this a lot with a lot of cancers and health conditions. Why do we see certain communities have a higher risk than others?
Yeah, so important to mention that. In the case of African Americans, it's kind of complicated, but it looks like there's a lot of difference in risk factors, perhaps behaviors and lifestyle factors that may lead to cancer, some of the ones that I just mentioned, for example. But I think there's also the issue, which is common for many cancers and diseases, unfortunately, that there tends to be poor access to care due to socioeconomic factors. We call these factors the social determinants of health. And so for this reason, it's so important, Kibin, that institutions, doctors, and even governments, of course, work hard to kind of close these gaps in healthcare access and screening and preventative services. And that's true for colorectal cancer and many other diseases. So that's a really important thing to highlight here in the Bronx. And I try and really highlight that with my African American patients as well. In the case of the Ashkenazi Jewish patients, it's not quite understood exactly what's going on there, but it is thought to be, and there's some good science that shows there are some genetic mutations that in fact are sort of yielding some of that increased risk. But also, as is the case with African American patients, a lot of that risk is accumulated through like behaviors and lifestyle. So the message out there is do what you can to change your risk factors, those risk factors that you can change, but of course get screened.
I'm so glad that you brought that up and explained that for us because I think it's a very important thing that a lot of people don't really look at. So I'm so happy that you explained that. Now we're talking about our background and how that could affect, your risk factor. Do pre-existing conditions affect this as well?
So, of those risk factors we mentioned, of course, there are some diseases. The specific one, inflammatory bowel disease, which actually does also cluster in Ashkenazi Jewish patients. So that is a pre-existing condition that can increase your risk. But I do want to highlight that, in fact, most Ashkenazi Jewish patients that get colorectal cancer don't have inflammatory bowel disease. The vast majority don't. So it's not like, oh, if I don't have inflammatory bowel disease, I'm all good. It's obviously not the case. We all need to get screened. There's other specific situations and family syndromes, which I won't get into the names of, that increase your risk. And those are, of course, predetermined or pre-existent, if you will. And then there's a rare situation where if you've had a childhood cancer and you had radiation to your pelvic or abdomen area during that cancer, that later on in life, you are at higher risk for developing cancer.
Now, when should people begin looking for signs and getting screened? We know that's super important. What age would you suggest, or when in your life should you start looking at screening?
So this is so important, Kibin. This is something that we have seen in the last several years. It's very clear from the evidence that we have that the risk has been steadily increasing for colorectal cancer in patients under the age of 50. The risk tends to concentrate in people in their 40s. And the really important thing I want to share is that, unfortunately, younger people in their 40s or even younger sometimes who get these colorectal cancers, that these cancers tend to be more aggressive. So it's really important to start screening now earlier than was previously recommended. So all societies and guidelines really have essentially dropped the recommended age for screening for the general population to age 45. It used to be 50, and now everybody's like, oh no, we got to start earlier. We got to start at 45. So we should start talking as a primary care physician. I start talking to my patients at 40 who are at average risk about kind of getting themselves prepared for having that screening test when they hit 45.
And can you tell us, we have about 2 minutes left, but can you tell us about Montefiore's enhanced screening efforts and FIT testing campaign?
Of course. So I'm so excited. most people know about having colonoscopies, right? Which is a really the gold standard of screening, an important way to screen. But not everybody wants colonoscopy. Not everybody is accepting of that, and that's fine. The most important thing to do is to just get screened with something, and it's important for the doctor to always give patients options as to how to be screened. The FIT test in particular is a newer stool-based test that we have here at Montefiore, which is really accurate in terms of its ability to find colon and rectal cancers. And it's very simple. It's an at-home test that you can take. You can get a little stool specimen, bring it back. The lab would process the result. It's very important, if the test is positive, that you then get a timely colonoscopy to find and remove any early cancers or polyps. But for many patients who don't want colonoscopies, the FIT test also offers a great alternative because it's simple, it's easy to perform, it's non-invasive. And of course, we all know patients don't like to have to take that prep and clean out and have the restriction to a clear liquid diet, which is, of course, necessary for colonoscopy, but is not necessary for the FIT test.
Doctor, thank you so much for joining me to have this important discussion. We're going to put the number up on the screen for colorectal cancer screening program, and you can learn more information through there. Once again, thank you so much for joining me, and we'll be right back with more Open BxRx Tuesday.